Tuberculosis, the most common infectious disease nowadays, it is caused by Mycobacterium tuberculosis. To know why it is so dangerous, we need to know the mechanism behind this infection. TB is a airborne droplet infection. When the active TB patient cough or sneeze, the bacillus enter into the lung, act as a foreign body engulfed by the macrophage. But TB bacillus survive inside the macrophage by inhibiting the phagosome and lysosome fusion, which is very important for a destruction of the bacillus, but it fails to happen. Then TB start multiplying inside the macrophage and release the cytokines and chemokines. These substances start activating furthermore macrophages. Later, the attacked macrophages start dying and form the caseous necrosis around the bacillus, and this necrosis is surrounded by the epithelioid cells, Langerhans cells, lymphocytes, and fibrous tissue. These group of immune cells form prison-like structure around the bacillus to prevent furthermore spread of infection. This is also known as granuloma. This is why tuberculosis is also called as a granulomatous infection. Granuloma plays very important role in the tuberculosis. In that strong immune patient, the granuloma will remain dormant and prevent further spread of infection. So no symptoms will appear. This is also known as a latent tuberculosis. But in weak immune patient, granuloma breaks and spread of infection happens and symptoms will appear. In the pulmonary tuberculosis, patient came with a greater than 2 weeks of persistent chronic cough. Initially, it is a dry cough. Later, it is a productive sputum cough. Then hemoptysis, that is blood in sputum due to destruction of the lung tissue. Then severe chest pain, which is worsening on breathing. In advanced cases, there is a shortness of breath also. A patient also complains of evening rise of fever and excessive sweat at the night. Laboratory diagnosis also plays a very vital part in the tuberculosis, in which early morning sputum sample collection is recommended because of high bacillary concentration which is present in the early morning sputum. Then we conduct a Zn staining, that is Zeal-Nielsen staining. The principle behind this test is mycolic acid present in the tuberculosis bacillus membrane will be resistant to the acid decolorizer and retain the red color carbonyl fusion. Then this bacillus appears as a red color rod-like structure in the blue background, also known as the acid-fast bacillus. In fluorescent microscopy of Ormain stain, the bacillus appears as a bright yellow-green in color, which is more sensitive. For molecular testing, we conduct CBNAT, that is cartridge-based nucleic acid amplification test, and cultural methods we use Lowenstein junction media. For management of the tuberculosis, we use a drug-based combination therapy in which it consisting 2 months of intensive phase and 4 months of continuation phase. Intensive phase for treating the actively dividing bacillus and continuation phase for treating the leftover or dormant bacillus. Intensive phase consisting of 2 months of HRZD, that is isoniazid, rifampicin, pyrazinamide and ethambutol. In the continuation phase, we include the 4 months of HRE, that is isoniazid, rifampicin and ethambutol. Here pyrazinamide is not included because it acts efficiently only in the acidic environment. Let's look in detail about these drugs, in which isoniazid act by inhibiting the mycolic acid synthesis and peripheral neuropathy as an adverse effect. So pyridoxine, vitamin B6 drug, is recommended along with this drug. Rifampicin acts by inhibiting the DNA-dependent RNA polymerase enzyme and hepatotoxicity as an adverse effect. Pyrazinamide disturbs the cell membrane transport and energy production in the bacillus and hepatotoxicity has an adverse effect. Ethambutol inhibits the cell wall synthesis in the bacillus and optic neuropathy has an adverse effect. But most of the tuberculosis become resistant to the first line drugs and emerged as a drug resistant tuberculosis. In the drug resistant tuberculosis, it includes monoresistance, in the sense only one among the first line drug is resistant. Polyresistance, in the sense more than one drug is resistant but not both isoniazid and rifampicin. Then multi-resistance, in the sense both isoniazid and rifampicin is resistant. Then extensively drug resistance, it includes isoniazid, rifampicin and fluoroquinolones as drug resistant. To overcome this emerged drug resistant tuberculosis, we are using newer anti-tuberculosis drugs, which includes bedaquiline, dilamanid, protamanid, linezolid, and clofazimide.